and thank you for joining today's webinar. My name is Chris Bondis, and I'm the head of marketing at PatientPing. I'm thrilled today to welcome you to our webinar topic, the CMS direct contracting model, how to prepare and succeed with real-time data. As many of you know, CMS recently released the direct contracting model, a voluntary payment model beginning on April 1st that offers participants increased risk options and the ability to receive capitation payments. The model is an integral component of CMS's strategy to redesign primary care as a platform to drive reductions in costs while allowing participants to drive consistent revenue, improve patient outcomes, and lower global utilization and costs. We're excited to have you all join us today to review the model in detail and discuss how participants can prepare for success. Before we dive in, I'll be covering a few technical logistics. First, attendees will remain muted throughout the webinar. We will have a Q&A portion at the end where you'll be able to submit any questions via the GoToWebinar control panel by clicking the question mark icon on the right-hand side. We will try to answer as many questions as possible, and if we can't get to all of them, we will certainly follow up with any of you whose questions were missed. Additionally, a copy of the webinar recording will be sent to all of you shortly after the session, as well as a copy of the presentation deck. With that, I'm pleased to introduce our speakers for today's session. First is Natalie Sheehan. She's a senior product marketing manager at PatientPing. And prior to joining PatientPing, Natalie held marketing roles at Biogen and Oxford Immunotech. Natalie holds an MBA from the Boston College Carroll Graduate School of Management and a BS from the University of Massachusetts Amherst. Next is Eli Brick. Eli is a growth director at PatientPing and is responsible for working with provider organizations, accountable care organizations, FQHCs, behavioral health, and community-based providers across the country to enhance their care coordination efforts. Eli holds a BA from Colgate University and has spent the better part of the last 4 years supporting providers on their transition to value-based care. Natalie, over to you.
Thank you, Chris, and welcome to all of our webinar participants. We have 4 goals for today's session focused on helping direct contracting participants prepare for and succeed in the new model. Today, we are going to first discuss the CMS Innovation Center's new direct contracting model. We'll highlight key considerations in preparing for direct contracting. We'll share how real-time patient event notifications can help participants succeed. And finally, we'll show how PatientPing can directly support direct contracting participants. To start, I'll give a brief overview of the direct contracting model. From a timelines perspective, the first performance period of direct contracting is scheduled to begin on April 1st, 2021. There's currently an implementation period running for the model, which will end on March 31st of this year. The implementation period is a voluntary option for prospective model participants and offers them the opportunity to prepare for the first performance period. In addition to the April 1st start date, there will be a second start date for an additional cohort of participants on January 1st, 2022. And the model is scheduled to run through the end of December 2026. CMS recently released the RFA for the new geographic risk option within the model, which is scheduled to start in January 2022. GEO intends to test if a regional approach to care delivery and value-based payment can improve health and lower cost for Medicare fee-for-service beneficiaries within an entire geographic region. CMS will accept applications for GEO from March 1st through April 2nd of this year. The primary focus of today's webinar will be on the professional and global risk options within the model, which are the options for the April 1st, 2021 start date of the program. Direct contracting is part of CMMI's strategy to redesign primary care to drive broader healthcare reform, improve quality, and reduce costs. It's a high-risk model that builds upon learnings and innovations from the next generation ACO model, innovations from Medicare Advantage, and commercial payer risk arrangements. CMS has stated that the model goals are to transform risk-sharing arrangements in Medicare fee-for-service, broaden participation in CMMI models, empower beneficiaries to engage in their own care delivery, and reduce provider burden to meet healthcare needs effectively. There are 4 types of direct contracting entities, or DCEs, that may participate in the program. The first type are standard DCEs. These are essentially established ACOs that are joining the model. They must have experience serving Medicare fee-for-service beneficiaries, and a minimum of 5,000 aligned beneficiaries is required for participation in the program, starting in the first performance period. The second type of DCE are new entrant DCEs. These participants have limited experience delivering care to Medicare fee-for-service beneficiaries, and they may not have more than 50% of participant providers with prior experience in shared saving models, such as MSSP, NextGen, or the Pioneer ACO model. They are required to have a minimum of 5,000 aligned beneficiaries by the 5th performance year, but with a glide path starting with 1,000 aligned beneficiaries required in year 1 and increasing by 1,000 beneficiaries each year until the 5th year. High needs population DCEs are participants that are tailored to Medicare fee-for-service beneficiaries with complex needs. High needs beneficiaries must have conditions that impair their mobility or meet one of the complex high needs special conditions for eligibility, which include significant chronic or other serious illness and an HCC risk score greater than 3, or an HCC risk score greater than 2 and less than 3, but with 2 or more unplanned hospital admissions in the previous 12 months, or signs of frailty as evidenced by a claim for a hospital bed or transfer equipment for use in the home. High needs population DCE participants are expected to use similar care delivery strategies as PACE organizations, and CMS has stated that they are required to have demonstrated capabilities and coordination of services that emphasize person-centered care. The number of required beneficiaries is lower for these DCEs, with 1,400 required by the 6th performance year, also with a glide path starting at 250 beneficiaries required for the first 2 performance years, with incremental increases from there until the 6th year, where they must have 1,400 aligned beneficiaries. The 4th and most recently announced DCE is an MCO-based DCE, announced this past December. These DCEs will be responsible for managing Medicare fee-for-service expenditures of dually eligible beneficiaries who receive Medicaid benefits through a Medicaid managed care organization. These DCEs must have a minimum of 3,000 aligned beneficiaries, and they will be eligible to participate in January 2022. CMS is expected to release a second RFA that includes all DCE types, including further details on this newly added MCO DCE early this year. For the purposes of this webinar, we will focus on the standard new entrant and high needs population DCEs, which are the entities that are eligible to join the model in April of this year. So from a beneficiary alignment standpoint, beneficiaries can be aligned to DCEs in 2 ways, voluntarily or through claims. Supporting one of the model's goals of empowering beneficiaries to engage in their own care delivery, voluntary alignment will take precedence over claims-based alignment in the program. I do want to call out that beneficiary alignment will be different for MCO-based DCEs, with MCO enrollment-based alignment used for these DCEs, where CMS will align all eligible full benefit, dually eligible individuals who are Medicare fee-for-service and enrolled in Medicaid benefits in the MCO. Claims or voluntary alignment will not be used for those DCEs. But focusing on the alignment criteria for the 3 DCE types that are starting this April, for voluntary alignment, Medicare beneficiaries choose to align to a DCE by electing a direct contracting participant provider as their primary clinician on mymedicare.gov or through a paper-based voluntary alignment form. DCEs are allowed to perform proactive outreach to beneficiaries for engagement on voluntary alignment within guidelines of permitted activities provided by CMS. For claims-based alignment, alignment will be based on primary care services provided by direct contracting participant providers, and a 2-year look-back period will be used. Given the alignment criteria, DCEs will want to consider their engagement strategies to drive voluntary alignment. The ability to effectively drive voluntary alignment among beneficiary populations will be critical to ensure that DCEs are meeting minimum beneficiary requirements for participation eligibility. And there are also additional benefits to voluntary alignment beneficiaries, which we will speak to later. DCEs that already have a large base of beneficiaries that they expect will be claims aligned will also want to consider proactive engagement for voluntary alignment to ensure retention of those beneficiaries, as competitive market dynamics for beneficiaries may emerge and voluntary alignment will take precedence over claims. So diving into the risk options within direct contracting, all DCE types will have two initial risk options, which are professional and global. As I mentioned earlier, CMS recently released additional details on a geo option that is scheduled to start in January of 2022. The professional option is the lower risk option within this model. With this option, DCEs will have 50% shared savings and losses with CMS and receive a capitation payment for primary care services only at roughly 7% of the benchmark target. DCEs will have the option to elect an advance payment for the remaining 93% of the payment, which would get reconciled against actual claims. The global option is a full risk option within the model. DCEs will have 100% shared savings and losses with CMS. They have the option to choose between primary care capitation or total care capitation. If they select primary care capitation, similar to the professional participants, they would have the option to elect advance payment for the remainder of that payment. As DCEs are preparing for the first performance year, given the level of risk exposure within the model, participants should be considering their care management resources that enable them visibility into patient care events and resources that support collaboration among DCE providers and external organizations in order to minimize avoidable utilization and financial losses and ultimately maximize savings. Want to now talk briefly about the performance year benchmark methodology. The benchmarks are grounded in historical and regional expenditures, and for standard DCEs, there are some nuances based on how beneficiaries are aligned. For the first 4 performance years, the benchmarks for claims aligned beneficiaries of standard DCEs will be baselined from a blend of historical and regional expenditures. Voluntarily aligned beneficiaries in standard DCEs, as well as all beneficiaries in new entrant DCEs and high needs population DCEs, will have benchmarks that are baselined in regional expenditures only. In performance year 5 and 6, all benchmarks will move to being a baseline from a blend of historical and regional expenditures. From there, the historical and regional expenditure benchmarks are risk adjusted, and then a discount is applied for global DCEs only, starting at 2% in the first 2 performance years and increasing by 1% each year until it hits 5% in the 5th performance year. The discount is applied to ensure that CMS obtains savings within the model. On top of that, a 5% quality withhold is also applied to the benchmark, which can be earned back based on quality performance, which I will speak to shortly. So when considering the performance year benchmark methodology, it's likely that standard DCEs will see higher benchmarks in the first 4 performance years for voluntarily aligned beneficiaries than claims aligned beneficiaries, where the benchmarks for voluntarily aligned beneficiaries will be based on regional expenditures. If standard DCEs have historically lowered costs of aligned beneficiaries, it is likely that the regional expenditures will be higher than a blend of historical and regional expenditures. With that consideration, standard DCEs will want to evaluate beneficiary engagement strategies to drive voluntary alignment and retention. Separately, all DCEs will want to evaluate resources and operational capabilities to drive success for the quality measures to earn back that 5% withhold. So digging into that 5% withhold, for the first 2 performance years, 4% of the quality measure will be tied to reporting and 1% tied to performance. After that, the full 5% will be tied to performance. The quality measures for the first performance year will be all-cause unplanned admissions for patients with multiple chronic conditions, which measures unplanned hospital admissions among beneficiaries with multiple chronic conditions. Second, risk standardized all conditions readmission, which looks at how many hospital stays result in a readmission within 30 days of discharge. And finally, days at home for patients with complex chronic conditions, which applies to high needs DCEs only, and looks at the number of days that beneficiaries with complex chronic conditions spend at home and out of acute and post-acute care settings. Additional proposed quality measures that will start in the second performance year are timely follow-up after acute exacerbation of chronic conditions and the consumer assessment of healthcare providers and system survey. Given these proposed quality measures, DCEs will want to consider operational resources and care coordination strategies to minimize avoidable admissions and readmissions, and beneficiary engagement strategies to drive timely follow-up after acute care events and to maximize CAHPS survey responses. The last model-specific topic I want to briefly cover is benefit enhancements expected to come with direct contracting. The anticipated benefit enhancements build upon those in NextGen and introduce new incentives to encourage beneficiary engagement, supporting the model's goal of empowering beneficiaries to engage in their own care delivery. Examples of these benefits are listed on the slide. I won't go through them all in detail, but it's important to note that there are several new and innovative enhancements anticipated and being considered for this model to support the broader innovations in care delivery. So to summarize the key considerations that have been called out thus far, overall direct contracting participants should be considering strategies for how they can maximize both revenue and shared savings within the model. To maximize revenue, participants should be considering strategies to drive voluntary beneficiary alignment. Voluntary alignment will have a direct revenue implication because it will first ensure beneficiaries are aligned to a DCE and thus increasing beneficiary volume and the volume of monthly payments the DCEs are receiving. And second, it may incrementally increase target benchmarks for standard DCE participants. Participants should also be thinking about how they will engage beneficiaries to support retention throughout the model. Initial alignment is important, but ongoing beneficiary experience within the model will be critical to ensure that they do not voluntarily align with another DCE, which would take precedence over that historical relationship and claims alignment. Finally, participants should be considering processes to support maximizing the quality scores to earn back that 5% quality withhold within the target benchmarks. Specifically, strategies to minimize unplanned admissions and readmissions, and beneficiary engagement strategies to ensure timely follow-up after acute events and to maximize CAHPS survey responses. To maximize savings, participants should be considering care management resources and processes to minimize avoidable utilization. Given the high-risk options within direct contracting, robust care management resources will be critical to proactively engage beneficiaries during care events to minimize avoidable utilization, minimize shared losses, and maximize shared savings. Additionally, participants will want to consider beneficiary engagement tactics that support proactive preventative care to prevent avoidable downstream utilization and costs. I'm now going to hand it over to Eli to discuss how PatientPing and real-time notifications can support direct contracting participants as they plan for success within the model.
Thanks so much, Natalie, for that overview of the model and for sharing some of those key considerations for participants. In this section of the webinar, I'm going to give you all a brief overview of PatientPing and then talk about some of the ways that we can support direct contracting participants as they work to succeed under the new model. PatientPing is the nation's largest ADT, or patient admit, discharge, and transfer data network and real-time care coordination platform. We use our network and platform to execute our mission, which is to connect providers to seamlessly coordinate patient care. We connect providers across the community and across the care continuum to enable seamless collaboration and care transitions. We do this through our national data network and engaging software applications that enable real-world care coordination workflows. Knowing where patients receive care in real time enables providers to thrive in both fee-for-service and value-based care environments, including programs like direct contracting, and ensures that patients are receiving critical care when and where they need it most. The PatientPing network is powered by the nation's largest network of ADT data. We have the most robust national ADT network across the care continuum, which is composed today of over 1,100 hospitals, 6,000 post-acute facilities, and more than 300 provider organizations. Our network covers over 43 million patients nationally, and we've processed more than 135 million patient ADT events over the 7-year history of the company. Access to real-time data and insights will be critical to both maximizing revenue and maximizing total cost of care savings under the direct contracting model. In that vein, there are 3 key elements of PatientPing's platform, which will help drive success for DCE participants. The first of which is pings, which are real-time notifications on care events across the continuum from both acute and post-acute settings. In complement to pings are spotlights, which are real-time interactive performance and insights dashboards on SNF utilization, 30-day readmission rates, and multi-visit high-utilizing patients. The data that powers both our pings and spotlight solutions comes from our diverse and robust national network of engaged hospitals, post-acute facilities, and provider organizations. Pings, or real-time notifications, power targeted care coordination for direct contracting beneficiaries. Care teams will receive a notification in real time whenever a direct contracting beneficiary experiences a care event in an acute or post-acute setting. This includes ED presentations, admissions to observation units, inpatient admissions, discharges to post-acute facilities, and discharges home. Pings enable real-time intervention to drive reductions in avoidable admissions and readmissions, and reductions in post-acute utilization and length of stay. These first 2 areas of opportunity result in direct savings for direct contracting participants. And lastly, real-time intervention drives increases in beneficiary engagement for voluntary alignment and retention, which in turn results in sustained or increased revenue for direct contracting participants. Spotlights are real-time and interactive dashboards support macro-level organizational coordination for direct contracting participants. There are 3 Spotlights dashboards, all of which provide real-time insights on macro-level trends, along with the ability to drill down to facility and/or beneficiary-specific information. The SNF management dashboard provides a month-over-month view of SNF readmission rates, along with average length of stay and overall admission volumes. Users can drill into each metric to view a breakdown by individual SNFs and further drill into an individual SNF's data to surface beneficiary care events. The dashboard enables macro performance tracking of skilled nursing facilities and effective collaboration with SNF partners to discuss opportunities for performance improvement. The hospital readmission rate dashboard shows overall readmission rates by month and allows users to drill into each month to view the breakdown of all readmission rates by hospital. Users can then drill into each hospital to view individual beneficiary care events. The dashboard supports real-time identification of 30-day readmission rate trends and powers performance improvement initiatives to reduce beneficiary readmissions. Finally, the multi-visit patient dashboard displays utilization patterns within a beneficiary population. Users can quickly view the number of beneficiaries visiting a hospital with buckets for patients with 2 visits, 3 to 4 visits, 5 to 8 visits, or 9+ visits in a given time period. You can then drill into any of those buckets to view the individual beneficiaries and their specific care events. The dashboard supports rapid identification of high utilizing patients and enables organizations to effectively and efficiently direct care management resources towards the highest impact beneficiaries to decrease avoidable utilization and subsequent costs. PatientPing's national network powers pings and spotlights and the ability to surface comprehensive real-time insights. Beyond that, our network also consists of engaged stakeholders, which enables us to facilitate bidirectional care coordination. With PatientPing, you have the ability to push critical beneficiary information to other treating providers across the network. When you do that, any PatientPing user can quickly see critical information for a beneficiary presenting to their facility. To give an illustration of what this looks like, an example may be a beneficiary who's admitted to a skilled nursing facility. Upon admission, that SNF is able to view that beneficiary's attribution to your DCE see your care team's contact information, access care coordination instructions from your care team, and view a full encounter history of that patient's prior encounters and visits at facilities across the PatientPing network. That context supports the SNP care team's ability to effectively coordinate care and drive an optimal patient outcome, which ultimately reduces the risk of a downstream readmission and avoidable costs. Pings, which drive targeted beneficiary intervention, along with spotlights, which drive facility-level coordination between hospital and post-acute organizations, in conjunction with our national network enabling bidirectional engaged coordination of care, powers rapid performance improvements for direct contracting participants, including reduction in overall spend, resulting in total cost of care savings for DCEs, specifically driven by reductions in avoidable hospital utilization and post-acute utilization, while also increasing beneficiary alignment and retention, which is directly supported by timely follow-up of beneficiaries at times aligned with patients' care events to drive beneficiary engagement and satisfaction, which result in continued revenue for DCEs. PatientPing has historically generated substantial savings for ACOs, and we partner with many of the most successful ACOs across the country to help drive shared savings and success under that model. In 2019, our network of next-gen ACOs earned over $260 million in shared savings. More than half of the top 20 ACOs in the country that earn shared savings are part of the PatientPing community. Additionally, our customers achieved an impressive 93% average pay for performance quality score. Also in 2019, our network of MSSP ACO partners generated over $517 million in shared savings. Our partners, our MSSP partners, made up more than 43% of the total generated savings from that program, and 50% of the top 15 performing ACOs in the country participate with PatientPing. We look forward to supporting the savings of our direct contracting partners in the same way that we have for those participating in CMS's next-gen and MSSP models. To demonstrate what these aggregate savings look like on an individual participant level, I'll highlight just a few key data points from case studies we've done with a few of our ACO partners. Houston Methodist Coordinated Care used PatientPing to generate over $680,000 in savings by reducing their average post-acute length of stay from 25 to 21 days. Additionally, they doubled the number of patients receiving care in their preferred network of post-acute partners by using PatientPing. St. Francis Healthcare Partners saw a 24.6% reduction in their 30-day hospital readmission rates from their preferred post-acute network, along with a 27.5% reduction in network post-acute average length of stay as a result of using the tool. And lastly, Pioneer Valley Accountable Care used PatientPing to reduce SNF costs overall by 25%. In review, I'll go through how PatientPing can help direct contracting participants both maximize revenue and maximize shared savings in the program. First, DCEs will want to evaluate strategies for how to maximize revenue, specifically strategies to drive voluntary beneficiary alignment and beneficiary engagement tactics to support retention. They'll also want to be sure to implement processes to maximize quality scores. PatientPing helps DCEs address these two considerations and maximize revenue through pings, which enable rapid post-discharge follow-up, supporting engagement strategies and increasing voluntary alignment and beneficiary retention. This maximizes revenue as it ensures beneficiary alignment and the associated monthly payments. Pings and spotlights together support reductions in avoidable admissions and readmissions, which are key metrics within the proposed quality measures. Maximizing quality scores helps maximize revenue because DCEs may earn back the 5% quality withhold from their payment benchmarks. Next, DCEs will want to evaluate resources and strategies for how to maximize shared savings and minimize losses, given the high risk level of direct contracting. Specifically, DCEs will want to allocate care management resources effectively and implement processes to minimize avoidable utilization. Implementing beneficiary engagement tactics that support proactive and preventative care will also be critical to success in the model. PatientPing helps DCEs maximize shared savings through the combination of pings and spotlights, which power strategies and workflows to minimize avoidable hospital and post-acute utilization through real-time notifications and insights on patients' care events. These actionable insights enable effective care coordination that drives down utilization and optimizes patient outcomes. Pings enabling timely post-discharge follow-up also support transitional care management workflows and create a beneficiary touchpoint to discuss utilization of available preventative services and benefits, which in turn will reduce the likelihood of avoidable acute care events in the future. So with that, I'll hand things back over to Chris, who's going to be leading the Q&A session of the webinar.
Thank you, Natalie and Eli, for the discussion. Before we jump into the Q&A session, I wanted to point out where you can find additional resources on direct contracting and PatientPing. To learn more about PatientPing, you can visit our website or contact us at connect@patientping.com. We've also linked to our ACO and PO pages where you can view more information and resources, as well as our direct contracting white paper. Lastly, before we start the Q&A session, we want to launch a quick poll for those of you who are interested in connecting with a member of our team after the webinar to learn more about the direct contracting model or how PatientPing can help support your organization. If you are interested, please click yes when prompted by the poll shortly. Great, thanks everyone. All right, for those who express interest in speaking with one of our team members, you'll be followed up with within a few business days after the webinar. So now we've got quite a few questions submitted already, and encourage any of you who have not yet done so to submit them via the question mark icon on the GoToWebinar control panel. All right, looking at these questions, Natalie, I think this first one is for you. Can participating in preferred provider TINs be changed each calendar year?
Yeah, that's a good question. So DCEs are actually required to submit a list of participant and preferred providers each year. So with that, they can add, remove, or edit providers. Additionally, DCEs can adjust provider lists mid-performance year as part of an ad hoc process. But any newly added providers would not contribute to claims-based alignment for that performance year.
Got it, thank you. One more for you, Natalie. Can a beneficiary be assigned to both a DCE with one entity and then an MSSP?
Yeah, so generally they may not be assigned to both a DCE and an MSSP ACO, with the exception of the new GEO component of direct contracting. CMS is indicating that ACOs and professional DCEs attributed beneficiaries could also be eligible to be attributed to a GEO DCE. And with that, they're also considering excluding beneficiaries that are aligned to global DCEs from attribution to GEO. But for MSSP specifically, they would likely not be assigned to a global or professional DCE and an MSSP organization.
Got it, thank you. Scrolling through here. This probably is best for Eli. Eli, what information will I see in patient-specific event notifications?
Yeah, so each ping or real-time notification will give visibility into, for a specific patient, the type of care event. So for example, an ED presentation, where that encounter or event is occurring, so the event location. You'll also see diagnosis information for the associated encounter or care event, along with up-to-date contact information on that beneficiary. So that's information shared by the patient at the point of care that's being pulled into the PatientPing platform and the ping. And then for further clinical context, you can also look at a patient or beneficiary's care team to see information on who else is attributed to the care team, along with a full encounter history on their profile within PatientPing, so where they've received care prior to the most recent care encounter.
Great, thank you. Natalie, another one for you. Can a DCE participate in the professional risk option and later move to the global risk option?
Yep, so if a DCE initially joins under the professional risk option, they're able to switch to the global option for the following performance year. They cannot, however, move from global to professional once the model starts. So they can step up from professional to global, but not the other way around.
Okay, great. Eli, one for you. Do I have to use PatientPing software or do you integrate into other platforms?
Yeah, it's a really good question. So our data can be integrated into other systems. The quick caveat to that is that our Spotlights dashboards do require use of the PatientPing platform, but we have flexibilities on our delivery of real-time notification data. So we can do HL7 feeds based on integrations, so like an outbound data feed. We can also do a Smart on Fire integration into EHRs, and we offer data delivered via a nightly SFTP file. All that said, the platform itself and our tool is specifically designed to support care management workflows with a really keen focus on the reality that when it comes to coordinating care and succeeding, particularly in risk arrangements, that data or information that's not delivered to the care team in a way that's simple, actionable, and real time, and if not real time, as timely as it needs to be to drive an engagement and intervention with a patient, ultimately begins to become meaningless. So there's flexibility, but the platform itself is designed to support and drive success in models just like direct contracting.
Got it. Thanks, Eli. Natalie, one for you. What happens if a DCE does not meet the minimum number of aligned beneficiaries?
So DCEs will not be permitted to participate in direct contracting if they don't meet that minimum number of aligned bennies each year of the model.
Got it. Okay. I think one more for you. Will voluntary alignment beneficiaries know that they are enrolled in a DCE?
Yeah. So part of voluntary aligning, the beneficiary must actively voluntarily align to a DCE, so they will be aware of that alignment and relationship when they do so.
Got it. Okay. Well, we're approaching time. If we did not get to your questions, we will respond and follow up directly, individually as well. With that, this concludes our webinar. Thank you so much for your participation today, everyone. And as a reminder, you will receive a copy of the presentation and slides from our team shortly after the webinar. Please don't hesitate to reach out if you have any other questions. Thank you and have a great day.